high above Caesar Rod. Okay, from high above a square in beautiful downtown Wilmington, Delaware, we are the Podcast Pediatricians. I'm Rob Walter.
And I'm Matt Gotthold.
And yes, we're back. Did they miss us, Matt?
I'm sure they've had better things to do.
We may sound muffled as we do this with our masks on today.
Mm-hmm.
It's been a strange spring, now a strange summer. And although this podcast weaves in medicine and humor, and we try not to bring partisanship or politics into play, it's hard to ignore world events. For those of you outside of Delaware, the reason we hesitated on our usual live from Caesar Rodney Square is that Caesar Rodney statue was removed from the square in mid-June, due largely to the fact that Caesar Rodney was a slaveholder. While that may have been illegal at the time, there was also abolitionists who were contemporaries of Caesar Rodney, who were against slavery, including many of the Quakers who lived in our region.
Yet he was also a founding father and a hero of the American Revolution. Most Delawareans know that he rode on horseback through the night in a thunderstorm in order to allow Delaware to vote yes to the Declaration of Independence in early July 1776, risking death by hanging by the British as a traitor, and all while battling disfiguring facial cancer. He was the president of Delaware during much of the Revolutionary War and fought in many Revolutionary War battles. He was also part of the Continental Congress and ultimately died in 1784 from his cancer.
So now we are having our long overdue national reckoning with systemic racism and how we treated the original owners of USA lands, the Native American peoples. I would encourage our listeners, if interested, to read the works of Nicole Hannah-Jones, including her 1619 Project essays that we talked about previously on the podcast. She also authored a more recent excellent article about reparations in the New York Times Magazine. Then have a dialogue about it with your friends and family. But of course, if we're going to touch on the Revolutionary War, we need to talk about the single biggest entertainment event of the summer, which obviously, Matt, was
the triple release of Jason Isbell, Larkin Poe, and Steve Earle albums. Oh my gosh, trifecta perfection. Dylan's album isn't too shabby either.
Okay. Or maybe the Eurovision movie. Who doesn't love Husavik, Iceland, right? But seriously, the correct answer to my question of the highlight of the summer is obviously Hamilton. So good. Did you see it, Matt? Did you see it?
Not yet. Although I will say I plan to. Okay. As opposed to you kind of spider webbing me into your usual Disney world, I do think that Hamilton's probably worth my while.
Okay, I'll take it. I loved everything about it. I recommend if you watch it, put the closed captions on so you can actually see the words that Daveed Diggs says when he raps really quickly. It's amazing. I love the drool on Jonathan Groff's face, which I think fit well with Mad King George. Sadly, as I think we may have mentioned last episode, we had to cancel Hot Topics Disney this year, but we definitely will be back at the Grand Floridian next year. Okay, so ready? I'm going to do it one more time. COVID days. Well, they were dark and long, COVID days, but we stood tall and strong, COVID days. COVID days. What kind of feedback did you get about our karaoke efforts last time, Matt?
Well, Rob, those bold enough to comment noticed two things. Number one, we should not give up our day jobs. This, of course, has been noted by our listeners innumerable times before and is understood by both of us as a given. And then number two, Bruce has nothing to worry about.
Nothing to worry about. Yeah, it was not good. I told everybody it was your idea, even though at the time you said it was mine. And it was mine. It was all mine.
Your idea, your lyrics.
Yeah, my lyrics. One of my friends who's a bigger Springsteen fan than you texted me afterward and just said, like, he was speechless. But not that good kind of speechless, like that awe time of speeches. He basically said he lost the power of speech. And he just gave me a sad emoji by text. But I do still like to hum it in my head. COVID days.
Yeah. Keep it there, please.
All right, so Matt, what's it like practicing pediatrics for you these days? The COVID cases are exploding the last week, over 60,000 cases a day. Everybody's setting records every day. The death rates are starting to come up. The past week, last 2 weekends ago, our phones just blew up. My poor partners who were on call that weekend with just millions of calls about, when to get tested and how to get tested. And the Delaware rates specifically have gone up. Now, all the surrounding states around Delaware are requiring all Delawareans to quarantine if we visit them, which back in the day, it was the opposite, right? Don't let the New Yorkers in. Don't let those Jerseyans in. Now it's like, stay away from the Delawareites.
Yeah, we're a dirty lot here in Delaware, I think. No, we talked about the fact several times now that this is going to be a long-term issue.
Yep.
It's hanging around and hanging around. And we also have to contend with the fact that the more information we obtain about the testing, the more we realize that it does not seem as though any protection from antibodies necessarily lingers on beyond a few months. Pretty concerning, right?
Not to mention the antibody tests themselves suck.
Oh, well, we've talked about that before, right?
Right.
But, it also then begs the question, when a vaccine finally has come to the fore and it seems to be useful, how long will the immunization last?
Well, you know what?
The effect of the immunization.
Later in this episode, we're going to bring it up, but we'll talk about it now.
Yeah.
I mean, I think that, and I've heard other experts say this, it's this vaccine, and there'll probably be multiple vaccines, and we'll have to choose, and different countries will have it. I think we've invested in like 7 or 8 of them right now, but it will be somewhat like the flu shot, that you'll get your corona vaccine perhaps every year. It won't mean that you can't get coronavirus. It'll mean that you'll less likely, and if you get it, it might be milder, just like we say with flu. And then the next year you get another corona vaccine. So hopefully coronavirus becomes like the flu. It's a completely different disease, but that you manage it and that you have some outbreaks. And for this year especially, it's going to be a dance, right? We'll talk about schools in a second, about it gets worse, you close, you open, you test. And that's remember that original article back in February about the dance?
Yes.
And that's where it's going to be, a dance of up and down until we get better vaccines or that elusive herd immunity.
Right. No, it's really going to be a challenge for us. I mean, I don't know about you, but I find my thoughts on this not varying broadly from day to day, but shifting a little bit this way, shifting a little bit that way as more and more information comes in. And I think the onus is on us to be able to be helpful to our patients and their families. But on the other hand, I think the onus is on us to stay up to date with what information is available.
Stay up to date and also be humble about the answer. Often I say a lot is, I have no idea.
I have no idea.
Here's my best educated guess.
Here's what I would do. You know, the old litmus of here's what I would do with my child. Right.
Right. And I'd be saying that more and more. And I'm getting tired of this mask. And then as we'll talk about goggles all the time. So it gets hot. I miss my cartoon ties. I know you miss my cartoon ties.
Only because it's another thing to mock you about.
I miss my fist bumps. Now I do an air fist bump. Ready, Matt? Ready, go.
No, you're on your own on that one.
La 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 la. Okay, Matt is not doing it.
No, I'm getting used to you wearing a mask too. It's quite the improvement, actually.
Thank you, Matthew. So in our offices, we've talked before. We've gotten pretty good at separating well visits and potential infection visits, and I think for both of us, our numbers have picked up. We got the PPP loan, and that really helped. And now the numbers are coming up. But we know with social distancing, there's just still less illnesses, which is nice. But it could be tough for our business model. And we're not going to get up to our previous numbers for a while until that vaccine or that herd immunity. Are you still doing a lot of telemedicine visits? And have you seen any COVID-19 cases?
Still doing telemed visits, really almost exclusively things like mental health and ADHD follow-ups, those types of things. You know, one would think that rashes are something doable via telemed, but I really have had mixed experiences there. You know?
I think the key, I agree with you, and we're seeing some weird rashes, and then that has now been listed as a possibility for COVID. But I think that, first of all, you need high definition. The free doxy is not good enough. I like FaceTime, and right now it's passed. But what really makes it, if you do the visual and you get emailed pictures, when I do those together, I can feel really comfortable. But you have to get those emailed pictures.
I've done that.
And that really helps.
You bet.
How about seeing any COVID cases?
A few, and a couple weeks ago, I may have mentioned this on the last podcast, but a little bit stymied by the fact that I had a baby who was delivered in the hospital to a dad who had and a mom who had a pending COVID test, and then an hour or so after the baby was delivered, the dad's test came back positive, and then of course we ended up needing to get the mom tested, and her test was positive, and then what do? Nothing, right? I mean, what can you do except for just be watchful? We did not test the baby,
ever?
Actually. We did not test the baby ever on the advice, actually, of our infectious
Dr.
disease
Epps,
score.
probably. So you
exactly.
just waited.
So why would you?
Right.
There's another. There was a 2-year-old at home staying with the grandparents, and
Right.
It begs the question: what, like anything else does in terms of what we do, what are you trying to accomplish here? What information will it give you that's
What does it
useful?
change?
What will it change? Absolutely.
Right.
And I think we need to ask ourselves that, and have the public ask themselves that over and over again as we confront this virus, because just like anything in medicine, there are a lot of things you could do. If a child comes in with abdominal pain, you can order a battery of tests and CAT scans and all that kind of stuff, but what will it accomplish for us in the short run? Not much, unless it's an ongoing chronic issue, right?
But as we'll discuss, the biggest issue is everybody else.
Exactly.
So it's a difference between getting back in a few days or being out up to 24 days. So we'll touch base with that in a second.
Indeed.
I had a couple. I think the first cases were senior week. Our Delawarean seniors going to Rehoboth Beach, and they were asymptomatic in our practice. So we haven't either had anybody significantly sick, and I'm sure we've had people we didn't even know had it. In our last episode, we discussed that multisystem inflammatory syndrome in children and mentioned that we hadn't seen any other cases. And the next day, our colleague, super pediatric cardiologist Deepika Thakur, did reach out to us to say, actually, they had 4 in our area. And a couple of them got really sick, intubated, pressors, but they all did okay. Their echoes are okay. So we certainly, it's there, it's rare, but still something to keep an eye out for. I did see one report earlier this week about a man in his 40s having the exact same thing.
Yeah.
So even though we think of it as a kid thing, and it's really not Kawasaki's at all, it's different. But this may not be just in children also, but still rare. Did you travel much? It's already July. Did you do much this summer?
We took kind of a hurried but necessary trip with my family. So my wife and my 3 kids went up to Vermont for 4 days. My middle daughter is just moved actually to Virginia to take a job. So we wanted to kind of cram a family vacation in just before
Let's
that.
toast, your child got a job.
Yay!
Yay!
Yahoo! Yeah. No, she has worked terribly hard and deserves everything she gets.
Are you still paying for her cell phone?
Honest? No, actually, I don't think we are.
Okay.
Although, yes, that's another story, isn't it? That's another story, right?
That's the final frontier.
That is.
When you're not paying for their cell phone.
That is.
I just got a text from your partner about COVID. I'll answer him later. Anyway, because he wasn't going to ask you, because obviously he wanted to get better advice than you.
Just different advice.
So I did a mini one with family. We went to a friend had a place in Jersey Shore and was very much kept inside. Wasn't one of those idiots out in the bars and things like that. But I had to go to Florida because my dad was really ill, and it was a few weeks ago. Now it wasn't the epicenter then, but went on American Airlines. They are not socially distancing. They sold every single seat. I figured it would be half empty. It was not. I had my N95s and my goggles. Mr. Dr. Nerd, everyone's looking at me.
Like it.
I didn't touch anything. I didn't go to the bathroom, not in the airport, anywhere. And it's still very stressful. And I'm not surprised that Florida is surging because it's consistent with everything they do as their national reputation of just being bizarre and not doing what they should do. And Florida continues to do that, except South Florida is like a big nursing home, and it's really scary. So many elderly people. So today, boys and girls, we're going to talk about some testing strategies and the opening of schools this fall and clearing student athletes for sports after COVID infections. Hopefully there will be sports. We're also going to cover some non-COVID stuff. But first, Matthias, our disclaimer.
We're sharing our own personal opinions on pediatric care. Always talk to your own pediatric caregiver about your child. Pediatric caregivers should always consult expert guidelines and consider their own community standards of care.
Okay, Maddie, are you doing COVID testing in your office? Last time we both said we were not, and I still am not. Although recently I'm looking into some office testing, even PCR, if it makes sense by how long it takes and also fiscally. I do think we both agree that the blood antibody tests that we talked about are horrible. So what are you guys doing?
Yeah, blood antibody tests, at least at this point, really are not just worthless, but they're confusing, I think, for everybody who has to try to interpret them. But we're not doing NP swabbing in our office right now since the supplies are still limited, and it seems like we're getting better turnaround times through our local hospital systems.
Right.
Yeah, one change, at least around us, is that for the NP swabs, the sites are doing anterior nasal swabs instead of deep, painful swabs, kind of like, the brain tickler back there, right? Since it still seems to be just as accurate.
Yeah, I was happy. I had to get I got myself tested by my choice before I went to Florida and multiple times after until the 2 weeks were over. And I thought, like, okay, I did it to other kids. I put it deep, and now it's my turn.
Oh, gosh.
And then they just put the front little anterior nose, and that was it.
Traumatized the kid with that NP thing.
No.
Yeah, when it all first started, I one of the couple that I actually did in our office, I did the NP swab, not realizing that this poor 13-year-old girl had a deviated septum, and man, her nose started bleeding, and it just wasn't pretty. I felt horrible.
You always get in a situation you just want to like go into a hole.
Yes,
and sink and die.
Look what I just did.
And they're looking at you, and it's always so pleasing when they go, "It's okay, we understand." You know them, and they know you were
it's
trying.
funny. She wasn't saying it was okay.
Yeah,
her mom said it was okay.
she's like, I hate you, Dr.
Right.
Capo.
I will kill you in your sleep. Yes.
And some patients are getting tested in community testing drive, and often they use the buccal swabs, which don't require a medical provider's order. And I haven't seen a lot of studies comparing the buccal to the NP or the anterior nares. I just don't think there are out there. What I've seen suggests that the mouth is not as accurate, and so I try to do the NP swabs. But that may change. And honestly, I hate to say it, but sometimes you end up saying, okay, it's good enough. If you need testing and you can't get it anywhere else, you can't get it quickly.
Sure. I mean, another dilemma we're increasingly encountering is what to do with the results that our patient families call us with to interpret. These tests are challenging enough since we have to try to interpret them in the context of timing, exposures, and risks to other contacts that may be elderly or ill or immune compromised, that makes it nearly impossible to say much at all about a test which we have no valid information regarding its accuracy. Additionally, we know some people with COVID-19 can be completely symptom-free. In fact, some of the newer numbers on this speak to up to 40% of those with the virus are asymptomatic. On a macro level, universal testing capacity will help us to determine better advice for our patients and for the community at large. But we also know that symptomatic COVID-19 does not necessarily have to include fevers or, for that matter, any specific symptom. So symptoms of COVID-19 can be more mild without respiratory distress that's acute, and other things can include things like GI issues, nausea, vomiting, diarrhea, and abdominal pain. Patients can also have chills, dizziness, and fatigue, and or sore throats, achiness, and headaches. When we get a call about any of these symptoms, we do not necessarily need to see the child if they're not that sick, and we can give our usual advice of rest, fluids, fever reducers for kids who are uncomfortable, but we still try to avoid any fever reducers since fevers help fight all infections, including COVID. But chicken soup never hurts. Rob, you put that one in there. I did. You're a chicken soup kind of dude.
Yep.
But we certainly cannot tell the parent that their child does not have COVID-19.
Yeah, so it's tough. So I had a call about a 3-year-old with a 99.5 temperature by mouth, congestion for 2 days, and then he was fine. So what do you do next? Do you test them? They want to send the kid back to daycare? Do you say that, 99.5 really isn't a fever? I mean, it's tough. It's tough to make that call because you're also making a call about that daycare and going back. And there aren't great specific guidelines about it. And if a child, and you don't want to bring them in if they don't have to either. If a child has some potential COVID symptoms and he doesn't end up getting tested, then if we assume that it's COVID-19, that child needs to be isolated for at least 10 days from the onset of the illness, and then including at least 3 days symptom-free before they can get out of isolation. But then the crucial part in the scenario is that all the other family members in the house needs to be quarantined for at least 14 days from their last contact with their child. And if you don't isolate that child completely in the house during those 10 days at first, and including using a mask, then everyone else's quarantine is the first 10 days plus the extra 14 days after. And how are you going to isolate a 4-year-old or a 5-year-old? You're going to stick them in the basement and throw food down there and keep your mask on all the time? So that's why it ends up getting crucial to get these kids tested early on, because it makes sense for the whole family. And once you kind of explain it to the family and touch it on who else is working at home, if there's grandma around, it becomes pretty much of a slam dunk that we need to test. And we're going to have to test a lot as things open up and kids get sick and they have to go back to school. And that gets back to what we're talking about, whether we want to do testing in the office, because we're not going to get out of this with keeping our schools and workforce functioning without testing a lot when anybody gets sick until we get that vaccine or herd immunity. Now, if a child is tested and doesn't have the novel coronavirus, then they can leave the house, up to 72 hours after the illness resolves, and the family doesn't need to be quarantined. We need to make sure that the testing turnover time is as quick as possible also. When I got my testing in Christiana, I got it back in less than a day. And our children's hospital was really good at doing it quickly, and then they got overwhelmed. It's a little bit of a weekly conundrum about where to get your tests, where you get the results back, and it's kind of asking people, wait, how long did this one take? How long did that one take? And that's really frustrating. Another frustration, Matt, have you had any kids who ended up being COVID positive who you didn't suspect? Like you said, one that was recently as a baby, but anybody else that you saw and you didn't suspect it, but then you found out, for some reason they got tested and they were positive?
No, but I'm sure that's happened in my practice. I just may not know about some of the other providers. I think the other thing that oftentimes people don't realize is that even though you're being tested on Tuesday, if you're doing something that's potentially risky or just by happenstance had something occur Wednesday, that test that you had on Tuesday is not going to reveal something that happened to you Wednesday. In fact, it's not going to reveal anything that happened to you Wednesday probably for at least 2 to 5 days.
Absolutely.
Right?
And also, if you get tested during your quarantine and it's negative, that doesn't mean anything because you can become positive up to 14 days later. So there's no reason, if you are being quarantined, start doing testing necessarily, unless for very specific indications.
And then, of course, the flip side of that is if you're tested, you don't have to keep getting tested over and over again with what is within the same realm of that time period, right?
Right.
Because, as we know, a lot of people will continue to shed the virus, even though they're not actively ill and may not even then be contagious, correct? So I think a lot of the adults in our community are dealing with workplaces that are requiring testing and retesting before you come back to work, which really doesn't seem to make a lot of sense, at least as far as the infectious disease people we discuss this with.
I know.
Are concerned.
And the one thing about it for our practices is that if you get that kid who's a surprise and comes back and is positive, by the guidelines, if you see a kid for a well visit or so, and you have a mask on and they have a mask on and they end up being positive, you don't need to shut yourself down or the office down. However, if you see a kid, and especially a younger kid who can't wear masks, and they turned out positive, and if they don't have a mask, and if you're not wearing goggles or an eye shield, then you have to quarantine for 14 days, and so is your nurse. So we, because of that, I think you guys did too, I mean, every single visit is a mask, and every single visit is goggles or an eye shield, no matter what.
A major shift in our thinking about COVID-19, which was highlighted in a recent excellent podcast from the New York Times called The Daily, is that COVID-19 is not a respiratory disease. It's actually a vascular disease.
Yes, and so now I really shifted my thinking. It's a vascular disease.
Yes, correct. So the symptoms come from tiny clots in the smallest blood vessels. Any part of the body with tiny blood vessels can be affected. These types of tiny blood vessels exist in lungs, kidneys, intestines, and the brain. COVID toes are from clots in the tiny capillaries in that area. Like most of the viruses, the novel coronavirus mutates every few weeks. Most of these mutations are not that important, but as we mentioned before, the early mutation from the Chinese version into what many are calling the Italian or the European version did likely make the virus 5 to 10 times more transmissible. And it's this version of the virus that is most common in the United States. Viruses have only one goal in their lives, to replicate as much as possible. So they'll move toward mutating into a more transmissible version themselves so they can multiply and spread. Interestingly enough, viruses also tend to mutate into less deadly versions of themselves because it does not enhance their primary objective, which is to replicate ad infinitum if they kill their hosts. Although this type of phenomenon, becoming less deadly, hasn't occurred much yet, There's certainly hope that over time, this will be the case with the novel coronavirus. Fascinating, right, Rob?
I think that's what
Yeah.
happened with the Spanish
Yeah.
flu 100 years ago,
Yes,
that
sir.
it did end up getting less lethal.
Right. It didn't dumb itself down. It in fact got smarter in terms of how do I survive longer to continue to replicate, right?
Right.
Absolutely fascinating. A third piece of COVID-19 puzzle involves the growing evidence now that there is really a proven risk for airborne spread. And we've been saying this from the jump, right, Rob? Through the invisible mist of a person's breath. So imagine you can smell a person's perfume or cologne an aisle or two away in the grocery store. This is the type of occurrence that we have to be aware is out there. Or when you walk by a window and the sunlight is shining through it, those tiny little particles that nobody realizes there, that's aerosolization. So this type of transmission is especially tricky and dangerous when we're indoors. Being outside has more and more really proven to be a key to lessen transmission.
This virus is becoming much more complicated than we originally thought. Dr. Fauci, who we both completely respect and support.
Rock on, Dr. Fauci.
He said yesterday that, and he's more experienced than anybody in the world probably, that he has never seen a virus that causes so many different types of problems. Okay, Matthew, first big subjects. Do you think schools should open up in the fall? I strongly feel that schools should open up. And I actually wrote an op-ed in the local USA Today paper about it last week. I actually sent it in at noon, and it was published online 5 hours later. I didn't even know until someone texted me and said, okay, you own this now if kids get sick, which then I kind of panicked like, oh my God. But I do stand by it. And in the opening of the piece, I said that most of the pediatric well visits I start with these few years have always started with, do you sleep with your phone next to you? But now my opening query is, how did you like online school in the spring? And the overwhelming answer was, again quoting Avenue Q, was that it sucked. Did you get that feedback, how for many it was just awful?
Yes, mostly. I mean, from both the kids and from their parents.
Right, and especially their parents.
Right.
There were some kids who loved it, and often because it was easier than regular school, because it was easier and they didn't learn very much. It was also the kids were less sleep deprived, which is a silver lining, because high school kids especially are very sleep deprived. Some kids who struggled academically or had few friends found that not going to school was a welcome relief, but that's a bit of a red flag that needs our attention. But as we said, and as you said, the vast majority of students and parents detested it, and studies indicate already that the children learned very little, especially children who don't have the luxury of a good computer and Wi-Fi and the benefit of a parent who can sit next to them and navigate all the lessons, which a lot of kids don't, especially in the urban areas and such. They just don't. The private schools in my practice seem to have done better from the feedback I got, and that's kind of amplified in Delaware because we have such a robust private school presence. And as I said, many of my patients with learning and focus issues really, really struggled mightily. The kids with ADD, after years of kind of getting their academic self-esteem up and making academic progress, it all kind of came crashing down. And also, again, those children who need additional support for speech, reading, and math, they got further and further behind. The emotional cost of the social isolation. Again, we have to open the schools.
Nutritional options. This is a biggie, much
In
bigger
this country,
than I think that most
yep.
of the middle class realizes. But there
Right.
is an entire huge population of children that really depend on the school system for their nutrition.
Their lunch and breakfast
For
or most of their calories.
A meal a day,
Right.
or two. And
Right.
that's, that perhaps that should be addressed, outside the realm of education, but it's what we have now, and it's feeding a huge chunk of our children, right? So children and the youth account for only 2% of the COVID-19 cases worldwide. And in the U.S., children have dramatically fewer hospitalizations and lower morbidity rates. Yes, there are exceptions to this generalization, such as those kids who suffer from multisystem inflammatory syndrome in children, but these cases are rare. While it's clear overall that the novel coronavirus is much more dangerous than seasonal influenza, this danger exists mostly in adults. To make a comparison, to date, 22 children in the U.S. have died as a result of COVID-19, as opposed to 166 who died from the flu in the most recent flu season. Pediatric populations are often a driving force behind community influenza outbreaks. Get your children their flu shots.
Get your flu shots.
Get your flu shots. But children do not seem to play the same role in spreading COVID-19. Many countries in Europe have already reopened schools safely after careful planning. These reopenings allow their parents to go to work.
And an article in Nature magazine in June showed that those under 20 have less than half the susceptibility for COVID than older people. And another article in Pediatrics this month highlights that kids are not significant drivers of COVID-19. There's been school studies from Denmark and Norway and France that have been very reassuring about how safe you can go back to school. But to be fair, they weren't opening up the school during a surge that we have right now. There were studies in Ireland showing that playing woodwind instruments and singing in choirs can really increase the virus spread, which is logical since both involve forcing air outward. So sadly, and I think both of us are really sad about that, things like band and choir may not be a good thing to do when school restarts.
That is sad. So the American Academy of Pediatrics has outlined key principles to reopen schools, and these include: we'll need to create smaller learning cohorts within each grade that will stay together in the classroom and during activities, often having the teachers rotate to the students instead of the students to them. We must utilize every available space in the school and get the students outside to learn and play. We just talked about outside transmission, right? Lower, correct?
Exactly. And then they also have contingencies for when it rains. So it's a lot of planning.
Yep. Frequent hand washing and masks must be mandatory when possible.
Must.
And social distancing with masks could safely be as little as 3 feet at times.
Now, that part got a lot of controversy because officially it's 6 feet. And they said, well, if people wearing masks and they're kids, which are lower rates of infection and spread, you can go down to 3 feet. Yeah. And that's a huge issue in each individual classroom. And that's what a lot of people are debating. But, I think there's no great study either way, but I don't disagree that they probably can be closer together than the official 6 feet if they're kids and they're wearing masks.
Mm-hmm. Transportation must be creatively reimagined with carpools within each cohort complementing school buses. Protocols to clean the schools during and after sessions must be developed. Now, the idea of carpools, this may be, I don't know, is this a little pie in the sky, Rob? Especially for families who don't have cars,
I know.
Families who don't have the means to arrange for these things. So,
right. Well, they have to think outside the box. That's all. Yeah. You're right.
Checking the temperatures of every child every day may not be very practical or even helpful compared to careful screening for symptoms and contacts. We should have school nurses with appropriate PPEs available to help. Testing for COVID-19 must also be readily available.
In the school, it should be readily available. And then the whole issue of should you test everybody before you start? And the AP specifically did not put that in because they may not be available. The cost issue, all these things are a huge cost issue. But I think that if you do have the testing and you can do that aggressively in the beginning, why not? If you're not taking away resources from other people. So a lot of the openings are starting with, let's try to get most of the people tested before we start. Just that moment of time, you're right, doesn't mean they couldn't turn positive, but for that moment of time to start. And also to make people and the teachers feel less anxious when they start. Contingency plans have to be devised when isolated cases arise, or in the event that a whole school needs to be shut down for a period of time of instruction and shifted to online schooling if there's a significant outbreak at the school or in the community. So yes, it's got to be kind of a hybrid here. It's also crucial to have social workers and psychologists available on site for both the students and the teachers. Again, that means money. We both see that anxiety and mood issues are really starting to spike in children who are isolated at home. Any families who don't feel comfortable putting their children in schools or have specific high-risk situations can opt out and get online teaching, perhaps conducted by teachers who themselves opt out because they have conditions or other fears about starting work. And so a lot of planning. But my point was it's July already. I mean, I see the private schools have been planning for this since April. Mm-hmm. And I don't see that urgency in some of the public schools, but maybe I just don't see it because I don't know all of them. But it just gets me worried that there isn't this urgency. Again, as we said in the beginning, I think there are greater mental health and academic risks to not opening than the risks of opening for kids. And especially on the younger age, you have to split them. I mean, kids under 10 are less risk than older teenagers, so that may play a role. And ensuring the education of our children is the first crucial step to ensuring the economic livelihood of our state, of our country. I ended my op-ed piece stating that I look forward to once again starting my well visits by warning against screens in the bedroom instead of lamenting screens substituting for our classrooms.
I know the purpose of your op-ed article was to advocate for the opening of schools from your perspective as a community pediatrician. The greatest obstacles to this plan will be how it's funded.
Yep.
The details of what you outlined, and the ability to best ensure the safety of teachers and other adult staff. Over 25% of our teachers are over 50 years old. Right?
Yeah.
That's a little dicey. Education, more than almost any other public service, is locally funded. I'm afraid that if not properly arranged for, unbalanced access to education during this time in our country may serve to widen already substantial educational gaps between rich and poor school districts and between private and public schools. As you noted, the private schools seem to be ahead of this. Part of that is because they have the money. Secondly, they can kind of mandate things as opposed to need to appeal to public consensus, which is what the public schools do. So there may be some reasons.
And third, they're really motivated because if
True.
they don't do it and
They
people
don't
won't
exist.
go there, they don't
Absolutely,
exist.
yeah.
Public schools will exist.
Yeah.
Privates don't have to exist.
Yep. So one way or another, it's going to take an incredible amount of money to hedge against the possibility that people who need education aren't going to get it.
Yep. A few days ago, the AAP followed up their initial statement, putting out a statement with two of the larger teacher unions to make it clear that if a community has a big surge in COVID cases, then the local officials should be able to delay opening or reclosing the schools. Just to say, again, everything depends on what's happening on the ground in that area. You have to be able to be nimble in terms of if there's outbreaks. And if we have to, again, as I said, if we have to prioritize age groups, the youngest ones should be prioritized to go back first, the elementary school kids, because they have lower risks. But those high schoolers need to get back.
Thanks.
They need to get out of the house. We need some kind of hybrid online and in person. And some of the schools that are doing 2 days a week in person and then 2 days a week at home or something. I mean, how do you have a family and have a work schedule when it changes and you're only 2 days a week? That's really tough.
No matter what gets thrown at people tend to adapt, but that's really going to be a challenge.
Yeah. All right. Well, we'll be
Wow.
right back.
And we're back. And a quick shout out to Julie Ortiz at triageforpediatrics.com. Julie and her crew does a fantastic job in terms of taking care of all those after-hour woes that we as pediatricians have in terms of answering phone calls. They were seamless in terms of making a transition to good COVID advice, and we truly appreciate them. So that is triage, 4, pediatrics.com. Julie Ortiz rocks it.
Second shout out to Jim Hansen, part of hi5s.com, high5s.com, website developing, PHP programming, and database development and firewall. His number is 877-483-1040 extension 1 or high5s.com. Great service for all your IT needs. We'll be right back.
And away we go, and back to our discussion. So do you miss professional sports, Rob?
I do, although I'm getting used to not having it, but the rhythm of the baseball season, the Phillies looked hopeful this year, got a good manager, the Flyers were resurgent, looking forward to those playoffs. I don't miss the Sixers, they were a hot mess, but Ben Simmons now going to be power forward, so who knows? And who knows about Eagles and college football, because those are sports that are tough to really distance. And I honestly think that there won't be college or high school football and full high school sports. I mean, I said this to a couple of kids. I made them sad, and I said, I don't know. He asked me my opinion, but I think that'll be tough. I mean, a lot of money in the Eagles, but billions of dollars, so maybe they'll come out and put on empty stadiums, but I can't see college and high school doing it. They just got to spend their resources just opening for education. What do you think?
Well, I don't miss it as much as I thought I would. I mean, agreeably, baseball and summer seem to be inextricably linked in my life. It's so familiar as part of this time of year, but we live in a time when there are lots of other ways to spend time. You know that we are both huge advocates for the power and benefit of reading, and of learning an instrument or a language. I read the other day that networks are having a hard time keeping up with programming because it's being consumed at such a tremendous rate. And that, in my mind, is really kind of sad. I mean, not that there aren't decent things to watch on TV, but so much of it is vapid and empty. And not that it can't be created, but that it needs to be created.
Except Hamilton, the movie.
Well, of course. The sports issue in the COVID era for us as pediatricians will involve clearing those kids who are affected by COVID for sports, if the sports resume. We mentioned before that the novel coronavirus can affect the heart in the multi-system inflammatory syndrome of childhood with a myocarditis type picture. In studies done of those hospitalized for COVID, 22% had heart involvement. So it will be wise to consider potential cardiac risks in our athletes. Just to be clear, we both support youth sports, but honestly, if it's a choice between a community putting resources toward getting the schools in a position to open versus keeping youth sports programs open, those efforts have got to go toward the schools at this point. Hopefully it won't be an either-or choice. A lot of guidance on clearing student athletes from a cardiac perspective came out of an excellent article in JAMA Cardiology in May.
And in that article, they did a nice overview of sports, and just like there are higher risk sports for injuries like for concussion, the same is true for the transmission of COVID-19. And you use your common sense. The lower risk sports include little contact and are outside, like golf, tennis, and track. Moderate risk sports might include soccer, field hockey, basketball, and volleyball. And the highest risk would be football, ice hockey, lacrosse, and rugby. And then wrestling, which I think is a wonderful sport, except for those whole weight restriction parts, to me is like the highest risk of transmission. I mean, they're all over each other. And it's usually indoor. I guess it could be outdoor, but I think wrestling would be tough. Decisions about sports will have to take into account the regional COVID infection rates.
Limiting travel for sports teams makes sense, as does changing the way members of teams are transported, with an emphasis on private cars instead of buses. Again, that gets back to what resources does a family have.
But a little
right?
bit easier to do it for a sports team with parents involved than to do it for the entire school.
Indeed.
I agree.
Indeed. Limiting the number of in-person spectators also makes a lot of sense. One of the information sources available that discussed the idea of quarantines was kind of interesting. Each team is in this circumstance together, and that if just one or two individuals don't follow the appropriate guidelines, it will hurt everyone. There is no I in quarantines, Rob.
Yeah. I put that in. I was like,
yeah, right?
That's corny. That's corny.
Make me say this corny stuff.
Yep.
Based on the JAMA article we mentioned, these are some guidelines pediatricians should use in order to clear athletes who had COVID-19 to return to play. Keep in mind, as we said, COVID-19 is a vascular disease. So, if the athlete is healthy, with no history of any COVID-19 risks, then he or she will be cleared with the understanding that they will adhere to social distancing and mask rules. If the athlete is COVID-19 positive but has no symptoms, then he or she needs to rest for 14 days following that positive test, meaning not participating in team activities either, without substantial physical activity, and then have a slow resumption of increasing activity after those 14 days. No retesting is needed if they are at least 14 days from testing, if they remained asymptomatic. So, in most cases, the asymptomatic COVID-19 positive athletes could go back to school after 10 days, but have to wait another 4 days to start their slow resumption of activity towards sports.
But according to these guidelines in JAMA, any student athlete with COVID-19 with mild to moderate symptoms without hospitalization, maybe some fever, achiness, diarrhea, they would need a 12-lead EKG and an echocardiogram and a high-sensitivity troponin blood test. Okay, Matt, how often do you order a troponin test?
Let me think about one. Never. How about you? No?
Never.
One of the reasons we went into pediatrics was so that we did not need to deal with heart disease so much or read EKGs. But in the COVID-19 era, we need to think about possible heart damage in our patients, especially our athletes. Elevated troponin can be a sign of ischemia and necrosis of cardiac muscle. The troponin test that we have occasionally utilized in the past, often in the ER setting, is sensitive to 0.01 nanograms per liter. The high-sensitive troponin test recommended for COVID-positive student athletes can detect it down to 0.001 nanograms per liter. It can detect cardiac damage even before ischemia and necrosis occur.
But hold the presses, Matt. Just a few days ago, thanks to Brad Bly sending it to us, the National Federation of State High Schools, the NFHS, and the American Medical Society for Sports Medicine, AMSSM, published recommendations from their combined expert task force with guidelines for these COVID-positive student athletes, which in my opinion makes much more sense. If a student athlete has a prior COVID-19 diagnosis, then they have to be cleared by their medical provider, who should specifically ask about cardiac symptoms, chest pain, shortness of breath with exercise, palpitations, excessive fatigue, decreased exercise intolerance. If there's none of those symptoms at all, and they've been asymptomatic, or even if they did have mild symptoms of COVID-19 without hospitalization, then they can be cleared to play. So that means no EKG, no echo, no high-sensitivity troponin testing. Now, if the exam or history reveals any of the cardiac-type symptoms mentioned in the screening, then the provider should consider at least an EKG and possible further workup. In that case, having other studies done with an input of a cardiologist would be wise, in my opinion.
These new guidelines also recommend supplementing the usual sports questionnaire with questions asking about any household contacts diagnosed at any point with COVID-19. Additional screening questions include asking about recent fevers, cough, shortness of breath, difficulty breathing, shaking, chills, chest pain or chest pressure or chest tightness with exercise, plus questions about any new fatigue, racing heart sensation, unusual dizziness, and of course, loss of taste and or smell, plus severe sore throat, nausea, vomiting or diarrhea, and any unusual rashes or painful discolorations of the fingers and toes.
So many things.
Golly, man.
Yep.
Also included are questions screening for athletes who might be at particular risk if they get COVID-19, including identifying those with severe asthma, not the usual typical mild, moderate, blah, 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 but really significant severe asthma, heart conditions, diabetes, chronic kidney or liver disease, and those who are immune compromised.
And I don't know about you, but I've been going on my way when I have families with mild asthma.
Mm-hmm.
Parents are so scared.
They are.
And I can't tell them that they don't have risk, but it's just showing that kids with mild asthma don't seem to be that high of a risk.
Yeah.
That they don't have to think like if they get this that, they're going to the hospital. And I think they need to hear that.
Although the flip side of that is I'm glad that parents are aware of the fact that their child with asthma has the potential to become more ill if they're presented with a challenge.
Right. And that maybe they should keep their inhalers and not stop them.
Indeed.
And keep them as healthy as possible.
Yes.
Now, if they have COVID-19 with any symptoms or not, again, as per the other guidelines, they shouldn't exercise for 14 days, including at least 7 days after any symptoms have resolved. Once the athlete gets clearance by their medical provider, they can gradually return to their sport.
If the screenings are all negative, then the athlete may slowly resume full activity under the guidance of their healthcare team. If an EKG or echocardiogram or high-sensitivity troponin was recommended due to risk factors and were positive, then the athlete needs to follow the myocarditis return to play guidelines, for which we refer to our pediatric cardiology colleagues. If a student athlete has significant COVID-19 symptoms and is hospitalized, then the recommendation is to get the EKG, echocardiogram, and high-sensitivity troponin level, along with a cardiology consult, and to consider further testing, such as cardiac MRI and or exercise testing and Holter monitoring. Once again, 14 days total rest after symptoms have resolved and a slow resumption of activity with careful monitoring is in order.
Now, I hope that we will have to deal with these, which means that if we are dealing with these sports clearances, that there is sports and the kids are going back to school. And again, we pray for a vaccine soon. There are 139 vaccines in preclinical trials out there, 21 now in human clinical trials, and the U.S. has invested in 7 of them. And I do think, as we said before, there'll be multiple different vaccines available. But again, it won't be like the measles shot, that you get a couple, it's 97%. It'll be something that we'll have to manage over years. So any other things about COVID till we get away from COVID?
Let's put that baby to bed.
Enough COVID. Let's do some pediatric potpourri.
Woohoo!
Let's start with Franklin and Marshall College, your alma mater, Maddie. So it's an excellent school. We joke about both our schools. It's an excellent school. But one of my patients was going there in the fall, and he brought me last month the medical history form to fill out. And then the mom said, can you look at this for a second? And they showed me the form, and there's very specific questions on the form that you fill out, and send by paper mail back to them. It includes, has the student ever had intercourse? How many different sexual partners has he or she had? What was the gender of the sex partners? If they've ever had a sexually transmitted infection, how often they drink alcohol, if they've taken illegal or recreational drugs or prescription medicine that was not prescribed for them. Now, both of us, I think, are totally in support of getting an accurate and full history from our teens and college-age patients. And those questions may be important to know, even including the gender of sexual partners, since there are higher risks with certain situations like male-to-male sex. But I totally agreed with the mom that this is not something that should be filled out at home on a piece of paper and sent in the mail. If any of those questions are to be asked, it's going to be with your medical provider, hopefully your primary care medical provider, and not just on a questionnaire. So what do you think, Matt?
I'm speechless. I mean, I'm appalled. These types of questions and their answers should not be taken lightly. I mean, I know that we live in the time of transparency, but this really goes to a relationship type of issue in terms of your caregiver, your provider. Any issues surrounding a patient's sexual history and or substance use history and the implications of them are best approached with the trust and the intimacy of a one-on-one conversation. This type of setting is not only more comfortable, which leads to better answers, more accurate answers, but also allows for obtaining confidentially the specifics of the answers in an unpressured manner, and it engenders trust and honesty. Wow. I'm really disappointed. Really disappointed.
Gotta say, boo dips.
Boo dips on that one.
Boo dips. All right. Mm-hmm. All right. Next. This is brief. An article in the Journal of Pediatrics in March 2020 entitled Evaluation of Home Phototherapy for Neonatal Hyperbilirubinemia concluded that the bottom line is that treatment at home phototherapy, works. We discussed this last year. We actually got picked up by local media about how you couldn't get home Billy blankets for a while, and then it got better, and we were using them. But now COVID-19 has hit, and I think it's going to be difficult to get nurses to go in homes to set it up. I've had 2 kids needing Billy blankets in the past couple months, and I could not get one. I don't know if you've had that.
Yeah, I think we've had still decent success with it. I think the other thing to look at is isn't there an advantage to having a home Billy blanket at home? Because who wants to be in the hospital with
exactly
COVID, right?
Exactly.
Yeah,
So I hope that's not going to be a trend. Next, I really like this one. It's from The Lancet in February of 2020, a study out of Duke. It's a study of a digital intervention for treating ADHD. The intervention was a video game, which was used to reduce the severity of pediatric ADHD. It was a randomized, double-blinded, controlled study, so as good as you can get. The researchers only used kids with ADHD who were not on medications or who had taken medications but were completely off their medications for the study. Now, one thing I like to ask when I have a kid who may have ADD, I don't know about you, especially boys, is, are they great at video games? And often the answer is, oh my God, they could do that for 5 hours, but 10 minutes of homework is torture. And so this kind of approach kind of fits maybe something that kids will actually do. Because a lot of these kids can really hyper-focus on things like video games. Not all of them, but many of them. And the possibility of treating their ADHD with a video game was very intriguing. So they looked at 857 kids ranging from age 8 to 12. Each got an iPad. They played a game called AKLTO1. I think if they're going to end up marketing this, they need a better name. Like Quest Saga Battle Death, something that would appeal to an ADHD type of 10-year-old boy.
Let's feed into that hyper-violent society we live in, Rob,
okay.
Shall we?
Okay, sorry. So the game involved a proprietary algorithm meant to improve attention and cognitive concentration functions by training interference management. Like, for example, at times during the game, the player is bombarded with distractors, which attempt to get him off task. And to be successful, they need to learn how to... Man. I'm off task. They did TOVA, T-O-V-A testing before and after playing the video game for 25 minutes each day. These tests screen for variables of attention. The participants were given 5 sessions of 5 minutes each for 5 days per week for 4 consecutive weeks. And the scores on the TOVA testing trended significantly upwards for every participant. And this one only looked at 1 month worth of treatment. An intervention that does not include medication, that's a video game, to me is exciting. And so, Matt, here's a tasty tidbit I thought about you, because you're such a stickler for grammar. Is irregardless a word? It's like if I said irregardless, would you correct me?
Probably. I really never considered it. It seems to be the same as regardless. And interestingly enough, I'm not sure if our listening audience knows this, but Rob writes the bulk of these scripts. And then he hands it over to me to edit because I think he dictates a lot of it. And who knows how it's going to turn out, right? So I put in irregardless, and the Microsoft Word refused to recognize it as a word. So,
Really?
What do you think, Rob?
Really? Well, but according to Merriam-Webster last week, irregardless is a word. They say it means the same thing as regardless, just with more emphasis.
Oh, for God's sake.
And so that sound you hear is the heads of English teachers all over the world exploding.
And even those of us who admire the language.
Gosh. And it reminded me of nauseous and nauseated.
Mm-hmm.
Like a person can feel sick and he's nauseated. But nauseous means causing nausea, like the smell of vomit is nauseous. Now, recently, Merriam-Webster also said that you can use those interchangeably. And I do ask patients all the time, do you feel nauseous? I don't say nauseated. So I think only really prickly physicians are going to have their heads explode.
I did learn something when you noted that, because I did equate the two. Yeah.
So did I.
Yeah.
And I still do. I don't change it. And lastly, in our potpourri, which maybe we should include under the setting of we are both really old, comes from Contemporary Pediatrics in January. They reviewed the newer IV fluid guidelines that came out back in December of 2018. So, Maddie, what is normal maintenance fluid? What would you say?
Pretty straightforward stuff, right? So it's a D5 quarter normal with some potassium after they pee.
If they're peeing, right?
Right?
D5.2 plus 20K.
Yep. Mm-hmm.
D5.2 plus 20K. It's always that. And we also were always taught that if someone needs IV rehydration, you start with normal saline for the initial rehydration, and then you can pivot to something else. It's usually D5.45 plus K. I remember that.
Boy, it's been a long time since
I
we've
know.
done this.
We both used to teach. You can go do the math and come out and what it would be if they're 10% dehydrated and their sodium is this. And it always came out to D5.45 plus K after the normal saline bolus. And then when they're completely back to rehydration, then you go down to D5.2 plus K. Yep. Well, Maddie, that was so 60 years ago. But they've completely changed. No one told me. Did they tell you?
Who knew?
No one told me. The new guidelines,
Yeah.
which only address sodium chloride and not potassium, and not dextrose, the sugar, and not special circumstances like hypernatremia or heart disease or cancer, essentially states that all maintenance fluids always should be isotonic, always normal saline.
Wow. So does that also officially make us, as in addition to being old, officially make us fall under the category of LMP or PCP? Remember we used to write that kind of
local MD
with derision, like in the charts when we were residents, like according to the LMP. I
think the category we're in now is boomer. Now you just got to call us boomer.
We're at that. Yeah,
it's not good.
Okay, boomer.
All right.
Mm-hmm.
So Maddie, I think we're done. So
but what let's go back for just a second, because I think this is quintessential in terms of my understanding of my career, and I think yours as well. One of the real reasons that we went into medicine was because it was perpetual, right? Because there was never an end. It's a career that encourages you to learn and to change constantly. And this was a perfect example,
exactly.
Right? Yeah.
Right. It just hit me though. Like
it is satisfying.
Part of the fact though, because we don't do hospital medicine, is we didn't even know this. It's been for a year and a half, and
did it matter?
No, but still, I like knowing stuff.
I like to know stuff.
All right. So
all right.
Say goodnight, Boomer.
Good night, Boomer.
Podcast Pediatricians Productions. All rights reserved.